Welcome to the SPARK webinar, Comorbid Autism Spectrum Disorder and Serious Mental Illness. We're very happy that you could join us today. Dr. Jean Fraser is the Executive Director of the Eunice Kennedy Shriver Center at UMass Medical School. She is also the Robert M. and Shirley S. Fifth Chair in Autism and Professor of Psychiatry and Pediatrics at the University of Massachusetts Medical School. Dr. Fraser is Vice Chair and Director of the Division of Child and Adolescent Psychiatry and holds a faculty appointment in the Graduate School of Biomedical Sciences. As co-director of the Child and Adolescent Neurodevelopment Initiative, Dr. Fraser directs a broad research program that addresses a variety of scientific problems relevant to advancing the understanding, diagnosis, and treatment of individuals with neurodevelopmental disorders such as early onset bipolar disorder, schizophrenia, and autism. Dr. Fraser is board certified in psychiatry and child and adolescent psychiatry. She has published 121 peer-reviewed journal articles and 19 book chapters. And in addition, she's received numerous honors and awards. And with that, I will turn it over to Dr. Fraser.
Well, thank you, Jonathan. I'd like to welcome everybody to today's webinar. And before we launch into the meat of the webinar, I just wanted to share my disclosures with you. First and foremost, I'm an active clinician, but I do research in an effort to improve the lives of individuals on the spectrum, and we have been engaged in clinical trials over the years. We're also funded through NIMH, NICHD, and NINDS. I think it's important for me to note that I will not be discussing any of the clinical trials that we have been involved in this webinar. I hope at the end of this webinar that you will be able to do the following: to discuss the DSM-5 criteria for and the prevalence of autism spectrum disorders, to describe the prevalence of psychiatric disorders in individuals on the autism spectrum, and have a frame for differentiating between whether an individual's functional impairment stems from their mental illness or from their autism spectrum disorder. And we will end up talking about current evidence-based interventions, and I hope by the end of the webinar you'll be able to describe those interventions. And we will be talking about medication treatments at the end of the talk, and it's important for you to know that most of the interventions that we will be discussing are considered off-label use, meaning they have either not been studied for the treatment of individuals with autism, or they have not been studied in children specifically. The only two medications that have been FDA approved for the treatment of youth on the spectrum are Risperidone. It is FDA approved to treat children between the ages of 5 and 16 years with autism, specifically to treat their irritability. It is not FDA approved to treat the core deficits seen in autism. Similarly, aripiprazole is FDA approved to treat children between the ages of 6 and 17 years with autism to target their irritability. Again, it is not FDA approved to treat autism per se. It's FDA approved to treat the irritability that we see in individuals on the spectrum. All other interventions that we'll be discussing constitute off-label use. Now, I'd like to talk about the DSM-5 and some of the changes that have occurred in this particular category. It used to be in DSM-4 and DSM-4-TR that the umbrella diagnosis was pervasive developmental disorders. That has gone away. The umbrella diagnosis is now autism spectrum disorders. This disorder includes and eliminates the distinctions between the following categories that used to appear in the DSM-4 system: autism, Asperger's disorder, childhood disintegrative disorder, and pervasive developmental disorder not otherwise specified. PDD is not used at all in DSM-5, and Rett's disorder has been removed. It's now categorized under, would be specified under associated with known medical or genetic condition. Now, another difference between DSM-5 and the prior version of the DSM is that we have two clinical domains that we use now to characterize autism. In DSM-4, we had 3 domains. So in DSM-5, we have domain A, which includes deficits in social communication and social interaction. This blends the social domain with the communication domain that used to exist in DSM-4. These individuals tend to have difficulties with social, emotional reciprocity, decreased social approach, and failure of normal back and forth conversation. They have reduced sharing of interests with other people and failure to initiate social interactions. Their nonverbal communication and social interactions are deficient. They have a deficit in understanding and in the use of nonverbal communication, such as eye contact, body language, and gestures. The criterion B consists of restricted repetitive patterns of behavior, and this includes insistence on sameness. They often have repetitive speech, stereotype movements, or repetitive use of objects. They have an insistence on routines, ritualized verbal or nonverbal behavior, and resistance to change. They at times get fixated on things, fixated on interests like the weather, like fans, like spinning objects, and they can have either hyper or hypo reactivity to sensory input or unusual interest in sensory aspects of the environment. So, for example, they can have indifference to pain, heat, cold. They can overreact to sounds or textures in clothing, noise in the cafeteria, and tags at the back of their shirts. The symptoms must be present in early childhood, but in some, these symptoms may not become fully manifest until the social demands in the environment exceed their limited capacities. Or they may be masked by learned strategies later in life. The symptoms must be impairing. They must impair their functioning. And this impairment is not explained per se by the intellectual disability or the global developmental delay. Now, the other thing that is nice about the DSM-5 is that we have specifiers, and the specifiers are attached to both domains, criteria A and criteria B. We rate the current severity, for example, from a level of 1 to 3, ranging from requiring support to requiring very substantial support. So there's ability to grade the severity of the symptoms. In addition, other specifiers include things like with or without intellectual impairment, with or without accompanying language impairment, having an associated medical genetic condition or environmental factor, having an associated neurodevelopmental, mental, or behavioral disorder, and finally, the specifier with catatonia can be used. This is all helpful and useful, and these specifiers actually in many ways allow us to really describe the patient before us by using severity ratings and the specifiers. The thing that's helpful about DSM-5 is that it brings us closer to the ICD, or the International Coding System. And another thing I'd like to highlight about DSM-5 is that unlike in DSM-4 and in prior versions of the DSM, we now can make a diagnosis of a comorbid ADHD and of comorbid schizophrenia and ASD in the DSM-5. Now, individuals on the autism spectrum are very diverse. No two individuals are alike. They're like snowflakes. There's a wide range of intellectual capacity, a wide range of communication level, ranging from nonverbal to being quite hyperverbal, and there are many presentations in terms of behaviors. Now, many people are very interested in this notion of prevalence, and this is really becoming a public health issue. In the United States, we started tracking the prevalence of autism back in 1975, and at that point, the prevalence of autism was 1 in 5,000. The most recent data indicate in 2010 the prevalence is 1 in 68. Now, how do we get these prevalence data? We actually get this data from something called the Autism and Developmental Disabilities Monitoring Network. Basically, they take medical and educational records and do a retrospective review of all children who are 8 years old across a number of sites, and they come up with the prevalence data. So in 2008, the prevalence was 1 in 88, and they found that 1 in 54 males were affected. The male to female ratio was 4.5 to 4.7 to 1, so it's about 5 to 1. In 2010, 1 in 42 boys are affected. Now, what are the reasons for the increased prevalence? It's probably multifactorial. We've broadened our diagnostic rules. We've changed the diagnostic criteria. We have better population sampling, better diagnostic methods, especially among lower IQ and higher IQ children. There's a greater awareness and recognition of autism, and in fact, there might be a contribution to environmental exposures, like pesticides in our environment. We know the prevalence is increasing and the extent of the challenge is increasing. We also know that autism is highly heritable, yet the etiology is elusive in 80% of cases. 75% of children with an ASD require treatment for emotional, physical, or behavioral problems. It is by far one of the most challenging disorders for families and for providers. Now, a lot of times families will come in and say, my child is in there somewhere. Please help us find him or her. Autism strains relationships. It increases stress on the siblings and other family members. And notably, the financial cost is enormous. To care for a person with autism over their lifetime, it costs $1.4 million. That increases to $2.3 million if they also have an intellectual disability. Now, this Venn diagram really represents the complexity and the challenge in working with individuals on the autism spectrum. In the middle, you will see autism, and then you'll see a number of circles and spheres that overlap. This represents the type of child that I typically get referred. The question often when they come in is, does this child have autism? Does this child have schizophrenia? Does this child have ADHD? Oh, and could you rule out a mood disorder? Could you rule out an anxiety disorder? So I think this slide just speaks 1,000 words. One thing that I'd like to add right here, because it's critically important, if a child or an adult is referred to rule out a psychiatric condition, and if there is a sudden or drastic change in behavior that warrants a more thorough evaluation, if it's sudden or drastic. And the reason I emphasize this is because often medical problems drive surface behaviors and emotions. About 50% of individuals on the spectrum have non-functional language. So if you think about it, if you have an ear infection, if you have a toothache, you get crabby. Imagine what it would be like if you couldn't speak, if you didn't have the capacity to communicate to someone in your environment what's going wrong. And in these instances, individuals, especially the nonverbal folks, but also those who are verbal, can actually present as if they had a mood disorder or agitation or insomnia because of the underlying medical condition. There's a high rate of things like gastrointestinal problems, asthma, and seizures in individuals on the spectrum. So those need to be really evaluated first before moving into the realm of psychiatric comorbidities. So what challenges do we see in individuals who are in the community, typically? And we see, and it's in order of most frequent to less frequent, we see most often in the community easily frustrated. We see inattention, hyperactivity, temper tantrums, irritability, fearfulness, and anxiousness. And at the lower end of the slide, you'll see destructive behaviors and self-harm. Those are less frequent in the community. But conversely, what brings individuals on the spectrum into an inpatient unit? As you can see, it's those aggressive behaviors, self-injurious behaviors, and property destruction, and less frequently things like temper tantrums, decreased functioning, sexualized behavior, and elopement. Now, what are the rates of psychiatric disorders in individuals on the spectrum? This is hard to actually answer well, primarily because individuals on the spectrum are often excluded from psychiatric research that looks at psychopathology. The other thing is that the studies that do exist, for the most part, vary widely across what they do. They have different sample selections, they have different methods for case ascertainment, and it's the critical source of the problem relates to how to identify the symptoms, how do you operationalize the symptoms. And unfortunately, we don't have many rating scales that have been validated specifically for use in individuals on the autism spectrum. There are rating scales that have been validated in the intellectual disabilities population, and they are employed in ASD studies, but they haven't been well validated in this particular population. Now, the other thing that's critically important for me to emphasize here when talking about autism so often people will say, well, isn't that anxiety part of their autism? There's a whole phenomenon in the field called diagnostic overshadowing, where symptoms of a disorder, a comorbid psychiatric disorder, are actually ascribed to the autism spectrum itself. And that becomes a problem because it is that comorbidity in individuals that actually are impaired that requires treatment. And if you ascribe the symptoms or the diagnosis to autism, then that comorbid psychiatric condition often gets overlooked and untreated. I want to share this slide with you. This is based on a study that was published in 2006. Leifer et al. Took what we think of in child psychiatry as the gold standard semi-structured instrument, the Kitty SADS, or the Kitty Schedule for Affective Disorders in Schizophrenia. And they took the one that was based on DSM-4-TR, and they modified it specifically for use in children and adolescents with autism by developing additional screening questions and coding options that reflect the presentation of psychiatric disorders in ASD. And they actually identified particular symptoms that a child on the spectrum may not have any capacity to understand. And they asked parents ahead of time about those symptoms. So let me give you an example. Guilt, which is a part of major depression. They would ask, as part of the semi-structured instrument of the parents, has your child or your son ever indicated at any point in the past that they have a full understanding of the meaning of guilt? And if the answer was no, then that particular question would be skipped. At any rate, they called this instrument the Autism Comorbidity Interview, Present and Lifetime. They piloted this instrument in a combined sample of 109 children and adolescents from 2 different cities, and these subjects ranged in age from 5 to 17 years, and also met criteria for autism based on our gold standard diagnostic instruments, the ADIR and ADOS. This was the first step towards a better tool to diagnose psychiatric comorbidity in individuals on the spectrum. They did publish their paper. They established reliability and validity for only 3 diagnoses, however: major depression, ADHD, and OCD. But it is important to note that individuals who had one disorder more often had 2 or 3 comorbid psychiatric disorders. The most common disorder that these children had was specific phobia, followed by OCD, and followed by ADHD. Now let's look at what's actually being done in the community. This is based on a national online registry that was established in 2006 out of Hopkins. It's called the Interactive Autism Network. It's based on parent report, and at the time that this was published in 2011, 4,343 participants were involved between the ages of 5 and 18. What they were interested in was what comorbid psychiatric diagnoses are being given to individuals on the spectrum by community providers. So it was not a research-assigned diagnosis. This is based on clinical practice in the community, and it allowed for the examination of factors associated with comorbidities such as age, gender, type, and the severity of ASD. And what they found was similar to what the Leifer study found. They found the significant subset had comorbid ADHD, followed by about 26% having anxiety, approximately 11% depression, 5% with bipolar disorder, and 1% with psychosis. 45.2% of those with one comorbidity had at least a second psychiatric disorder. The older the age, diagnosis of Asperger's disorder, greater social impairment, non-Hispanic ethnicity, evaluation by a psychiatrist or psychologist, and maternal psychiatric illness were associated with psychiatric comorbidity. Now, moving forward, I'm going to really concentrate on serious mental illness. I'm going to predominantly concentrate on depression, bipolar disorder, and schizophrenia, and their prevalence and how they present in individuals on the spectrum. So let's start with anxiety and depression, specifically in high-functioning individuals on the spectrum. It used to be called Asperger's disorder, but now it's more high-functioning ASD, according to DSM-5. We do know that depression is one of the most common psychiatric disorders in ASD. Individuals with ASD and comorbid depression are very likely to have a family history of depression. We know that approximately 65% of adults with high-functioning autism suffer from anxiety and depression as compared to 18% in the general population, which is a huge difference. We also know that there is phenotypic overlap between ASD and depression. Autistic symptoms may mask cardinal features of depression, and symptoms of depression in ASD may be atypical. And I'll share more about the presentation in a little bit. So what are the signs of depression in ASD? It's critically important to note that when there's a comorbid psychiatric condition, the proof of the pudding is a deviation, a sharp deviation from their baseline presentation. That is one of the most critical points. They have to have a deviation from baseline. So in individuals on the spectrum, we sometimes see either an intensification or a decrease in autistic symptomatology with the onset of depression. So for example, if an individual on the spectrum at baseline engages in ritualistic behaviors or obsessions, that with the onset of depression may either increase in an agitated way or decrease due to lack of interest. There are other reports that indicate loss of interest in repetitive behaviors that occurs with increased social withdrawal and decreased adaptive behavior. So atypical affective changes occur. They can have increased aggression, increased irritability, increased agitation, labile moods, preoccupation with themes of death. What are the suicide risk factors in individuals on the spectrum? They include the following: being between the ages of 12 and 20 years old, being male, having another psychiatric disorder such as GAD or major depression, and being the victim of bullying. Now let's talk about bipolar disorder. What is the prevalence of bipolar disorder in ASD? This is actually a little more difficult to answer. The studies vary. Janet Wozniak in 1997 published a paper that was based on psychiatric clinical referrals, and they looked at all youth in the clinic and found that 27% of all youth studied who had an autism spectrum disorder also had bipolar disorder. This particular group of children consisted of 12% of the overall sample described as having bipolar disorder. On the other hand, other investigators have not found a higher rate of bipolar disorder. There's several studies that have looked at youth with ASD who also have a family history of bipolar disorder, and they compared them to those youth with ASD without a family history of bipolar disorder, and they found that those youth who had a positive family history of bipolar disorder had extremes of affect, cyclicity, intense obsessive interests, neurovegetative symptoms, and regression. Piven and colleagues found a higher rate of MDD in family members of individuals with bipolar disorder and major depression, but they didn't find a higher rate of bipolar disorder. And DeLong and Dwyer found that 4.2% of relatives of folks with PDD, as it was called back then, had bipolar disorder. So how can you tell if somebody has a bipolar disorder? Well, there's a sharp change from baseline. There's a deterioration that occurs in cognition, language, behavior, and activity. Like with major depression, the symptoms of bipolar disorder may be masked by symptoms associated with ASD. But again, I emphasize, baseline behaviors change. They may become more intense or exaggerated during manic or depressive episodes. Let me give you an example. A youth that I treated when I was head of child outpatient at McLean Hospital presented to me, and his mother was very, very concerned because he wasn't sleeping. He believed he had a girlfriend. His speech was more pressured, and his baseline obsession with soap became so robust and increased in nature that he was staying up all night washing and rewashing all the clothes in the house, even though they were already clean. And the mother was at her wit's end because he was using all of their laundry detergent. And he was keeping everybody in the house up all night long. Through a thorough examination of the boy, it was very clear he had a sharp change from baseline, that he had an episodic presentation, that he was manic, and we started him on appropriate pharmacotherapy, and he would return to baseline functioning and was able to complete high school. Now let's talk about childhood onset schizophrenia. This is based on the study that emanates out of the intramural of National Institute of Mental Health. I was an investigator as part of this study many years ago. What we found is that up to 55% of youth who had childhood onset schizophrenia, meaning they had onset of their psychosis prior to the age of 13. It's very rare, but it does exist. But up to 55% of these youth had pre-psychotic developmental disorders that were similar to autism. They had language delays, motor development abnormalities. They had deficits in communication and social relatedness. Based on that NIMH study of childhood onset schizophrenia, a full 28% of the youth actually had a comorbid presentation of childhood onset schizophrenia and autism spectrum disorder. Now it's confusing. It's a quagmire. And if you just look at this slide, you can just look at a couple lines. There is overlap phenotypically. On the left-hand side, you see an autism impairment in nonverbal communication. On the right-hand side, in schizophrenia, you see social withdrawal. So how do you tell the difference? How do you tell the difference between lack of varied spontaneous play and disorganized behavior? How do you tell the difference between abnormal preoccupation with stereotyped interest versus delusional thinking? It's difficult, but there are two things that are really critically important in this differential. Number one is that sharp change in baseline. In cognition, just as you would in a person who's experiencing psychosis in what we call the neurotypical population, folks who don't have ASD, there is a change. There is a deterioration from their baseline. And the hallmark of psychosis are delusions and hallucinations. The primary set of questions that everybody asks is, well, how do you tell the difference? How do you know where the dysfunction is emanating from? And the cool thing about this, from my perspective, is this allows you the opportunity to be a detective, because it's complex, but you can figure it out. The great thing is that individuals with ASD come with prior assessments. The majority have been identified during school age. Often they have seen PCPs or prescribers. If they've been involved in the school system, they come with things like a clinical global impression scale. They come with neuropsychological testing. They come with a Vineland. So I want to give you an example here, because you can look at what their scores and their testing prior to onset of serious mental illness and compare it to the scores and testing after the onset of mental illness. Here's an example. 17-year-old man came in to see me. He was described by mother as a passive infant. He soothed with difficulty, had moderate response to change, some difficulties with sleep. He was diagnosed with ASD at 3.5 years. His CGI was 61 prior to onset of his serious mental illness, and his neuropsych testing was average to above average. Then at age 12, he had extreme decompensation in mood, behavior, and cognition. He had auditory hallucinations. He was highly distracted, and he was diagnosed as having schizoaffective disorder. After multiple medication trials, he actually was somewhat better. They repeated his GAF after he had achieved some response to his pharmacotherapy, and it was 41, and his neuropsych testing was very low to average. Now let's move to talk about interventions, and we'll be speaking about what we know in terms of evidence basis. The general aims of interventions are to reduce unsafe behaviors, improve self-regulation skills, increase positive social interaction, increase parent-guardian management skills, and to acquire adequate community supports to sustain for those who are inpatient post-discharge. The treatment for autism spectrum disorder is multimodal in approach. Typically, it involves behavioral interventions, educational interventions, and in the majority, pharmacologic treatments. It's important at every step of the way to target the individual's appropriate developmental stage. The mainstays of autism treatments include things like behavioral approaches. Like applied behavioral analysis has the most evidence basis behind it. Most individuals require speech and language therapy, and kids in school attend things like social skills groups like Lunch Bunch. Common additional treatments include the following: OT, PT, CBT. There's an emerging literature that CBT is actually quite helpful for anxiety, especially in high-functioning autism. And I've listed some other interventions that can be helpful. Now let's talk about psychopharmacology and what we know. This requires in-depth assessment, assessing symptoms, detailed developmental history, medical history, detailed history about changes in the environment, detailed history about changes in behavior, and it's important to ask about things like vitamins, supplements, or use of chelating agents. Now here are some instruments that actually are used. I talked about the autism comorbidity interview, present and lifetime. 3 diagnoses have been validated. They are MDD, OCD, and ADHD. This is rooted in DSM-4-TR. It's only a child instrument. Then we use things like the Clinical Global Impression Scale, the Aberrant Behavior Checklist, Children's Psychiatric Rating Scale, and the Children's Yale-Brown Obsessive Compulsive Scale that's been modified for pervasive developmental disorders. Unfortunately, for adults, there are very few validated instruments. We typically use instruments that have been validated in individuals with intellectual disabilities. There is an instrument that's being researched called the Autism Spectrum Disorders Comorbidity for Adults, but most of the instruments that are used are not validated in ASD per se. Target of medication. We have no medications that treat the core features of autism. What we typically treat are behavioral problems like aggression, hyperactivity, anxiety, and sleep. Now I'm going to go through what we know and what we don't know about medication treatment. Now a grade A means good. It's just like in school. Grade B is less good. Grade C is in the middle, and D, that's bad. So if you get a grade A, that means there's sufficient evidence. It means there's several high-quality studies, and further research is very unlikely to change our opinion about the efficacy of this agent. So aripiprazole gets a grade A. It's FDA approved for treating irritability, as I mentioned. Risperidone gets a grade A. And as you can see, I give the dosing ranges studied, and for the most part, for those of you who are prescribers, you can see that the mean dose across most studies is moderate. It's not a high dose. For aripiprazole, it's 8.6 milligrams. For risperidone, it's 1.8. Now, methylphenidate for irritability and aggression gets a grade A. Divalproex or Depakote gets a grade B. And there's one small open-label study in buspirone that showed that 9 had marked response and 7 had moderate response. What about hyperactivity? Methylphenidate gets a grade A. Atomoxetine gets a grade B. Clonidine gets a grade C. And guanfacine gets a grade B. Now, one of the most important features of ASD that we contend with is repetitive behaviors. And I do recommend using SSRIs, but the data that we have for the use of SSRIs is really rooted in studies of adults. Unfortunately, fluvoxamine and fluoxetine have a positive signal in adults with ASD. The child studies, unfortunately, have all pretty uniformly been negative, and children tend to get activated on SSRIs. I want to share one study in the next slide that visually will demonstrate how the active drug did not separate from placebo. Atypical antipsychotics can decrease repetitive behaviors. This was seen as a secondary outcome in the irritability studies, and Depakote may also benefit repetitive behaviors. Here's the citalopram study that involved 149 youth with ASD, and as you can see over the 12 weeks, the red line is not any different than the black line, and so the active drug did not outperform the placebo pill. Now, the most common set of comorbid diagnoses apart from ADHD are depression and anxiety. And we've got a huge vacuum here in terms of evidence basis. There's little guidance in the literature. There is support for the use of selective serotonin reuptake inhibitors in adults. But in children, as I mentioned, there's high activation somatic complaints. For sleep disorders, we actually have evidence that melatonin can be helpful, up to 6 milligrams per day, without any significant side effects. Now this is a novel medication that there's one study that indicates that it actually might be helpful. This is a chloride channel antagonist that reduces GABA activity. This one study of 60 children found that it reduced the core deficits seen on the childhood autism rating scale scores. But it's only one study and it needs to be replicated. And finally, I put this slide in here to let you know that more often than not, combined treatment is the rule, not the exception, in individuals on the spectrum. Yet, until 2012, there were very few studies that had been published that actually looked at combined treatment and whether it was better than one treatment alone. So this represents the first of its kind. This was a parent training module and risperidone. They basically looked at parent training plus risperidone, risperidone alone, or risperidone plus wait list, and they found that parent training plus the med showed modest benefit over medication alone after 24 weeks. The unfortunate thing is the efficacy was not sustained over the follow-up period. Now there's also another study that looks at melatonin plus CBT for insomnia that was recently published, and it shows that the combined treatment of CBT plus melatonin had a trend towards being better than the other treatments alone. So I want to leave you with some clinical pearls for prescribing in ASD. It's important to start with agents that have better adverse effect profiles before moving to atypicals. The old axiom is still true: start low, go slow. Effects are maximized at lower doses than used in typically developing children, and often medications are less tolerated than in typically developing individuals. Key take-home points: DSM-5 has some changes. We have one category and two core domains with specifiers. Autism is complex. It's important to assess for psychiatric comorbid conditions. I've provided a frame for determining the root of an individual's functional impairment, ASD versus SMI, and I've covered evidence-based interventions. I provide you here with some tools that might be useful in your clinical practice. Again, these are tools aimed at families and children, but they can also be informative for adults who are on the spectrum. And with that, I'd like to thank you very much for your attention. And I think we have some time for questions.
Thank you, Dr. Frazier. Yes, we do have a few minutes left, and we did receive a couple questions. The first question is, could you speak to the relationship between autism spectrum disorder with a co-occurring diagnosis of oppositional defiant disorder?
That's a very good question. And I was actually looking at that over the weekend to see what the prevalence is of ODD. The fact is we don't have validation of ODD in this particular population. The truth is, in my clinical experience, if there is a change from baseline and a child develops oppositional defiant symptoms, often the driving psychiatric comorbidity is either an anxiety disorder or a mood disorder. And once that is treated, often the oppositional defiant disorder symptoms will go away.
Okay. We do have one other question here, and actually two more questions, I've just been told. Any sources, treatment techniques, or resources for autism spectrum disorder and fetal alcohol dual diagnosed individuals?
That's also an excellent question. I believe that Children's Hospital has, in the Massachusetts area, has a fetal alcohol syndrome clinical program, and they do see individuals on the spectrum as well. Nationally, I'm not aware of all the resources in this particular area, but I would encourage you, whoever asks the question, to go on the website and look, at the Fetal Alcohol Syndrome or Association and see what they might have, which is what I would do, and go to your local children's hospital to see if they have a fetal alcohol syndrome clinic.
Okay. Another question that came in was, what is the difference between comorbidity and dual diagnosis?
It's essentially the same thing.
The next question that came in is, what's the best way for people who aren't psychiatrists to stay up to date on behavioral pharmacology as it pertains to autism?
Mm-hmm. Are you asking about mental health providers, like therapists? I'm sorry.
Yeah, I would say that would be the case.
Okay. Yes. So I would recommend, there are often the American Academy of Child and Adolescent Psychiatry puts on pharmacology institutes, both in January and also at the annual meeting. Particularly for those of you who are child providers, I would really recommend going to those psychopharmacology institutes because there almost uniformly is at least one presentation on psychopharmacology in autism spectrum disorder. For those of you who are primary care providers, there's also an institute at the annual meeting that's geared for primary care providers, and very often there's a presentation on psychopharm in individuals on the autism spectrum.
Okay, we still have a few minutes, and we still have a few more questions.
Okay.
The next question is, if someone with autistic spectrum disorder reports hearing voices, how can this be differentiated from obsessive thoughts or even a learned explanation if the person has been in an inpatient setting and heard others giving this response?
Mm-hmm. Well, that's a very good question, and that's part of what you have to actively tease out. And I don't have a litmus test to be able to say this is what you do and this will give you the answer. What I would say to you is that whether it's an adult or a child, it's important to talk to people who know that individual before they came into the hospital. Something got them into the hospital to an acute level of care in the first place. And to find out what their baseline thinking pattern is relative to what brought them into the hospital. It's really not, when you see an individual on the autism spectrum who's actively hallucinating, it really does look very much like a neurotypical individual. They're preoccupied, they're responding to internal stimuli. It's not an obsessive thought. And it comes with, a decrease in cognitive capacity, a deterioration, often with lack of attention to hygiene. So you have to look at the whole picture to determine whether you're dealing with a psychotic disorder or not.
Okay, Dr. Fraser, just a couple more questions.
Okay.
Is it true that the age of a child's parents is correlated with their chance of being autistic?
There's actually some literature to suggest that may be true. There's other literature that speaks against that, but it is an area of active investigation.
Okay, and the last question we have for you. It seems like most have autism as a primary diagnosis. Do you see children with a serious mental illness as primary and autism spectrum disorder as secondary?
I would say based on my clinical practice, I would answer yes to that, because I see a lot of these individuals who are high-functioning autism who fall through all the cracks in all of our systems of care. And for the majority of them, it is not the autism that's impairing their functioning. It is their comorbid serious mental illness that is impairing their functioning. Similar to, DSM, prior to this iteration, would not allow you to actually make a comorbid diagnosis of ASD with schizophrenia. And I think that there's a downside to that, but there's some value to that, which is it used to be that if with the onset of psychosis, the umbrella diagnosis of schizophrenia would wipe out the diagnosis of PDD or ASD. The good part of it is that approach highlights the most impairing component of that individual's presentation. The downside is that in the older iterations of DSM, when you eliminated that ASD diagnosis, when it still was there, it actually was problematic for some individuals in the clinic, because then they could not easily access autism-specific supportive services that they continue to require, in addition to the pharmacotherapy for their active psychotic illness. So happily in DSM-5, we can give them a comorbid diagnosis, but I would say until that mental illness is adequately treated, that needs to be the leading diagnosis, and that needs to be the thing that providers target to get them back on their road to health.
Thank you, Dr. Frazier. That concludes today's webinar. I just want to remind folks that are still on to please be on the lookout for email announcements for future Spark webinars during this year. And please don't forget to visit our website, our Spark website, to join our mailing list. And as I mentioned, you can also follow us on Facebook, Twitter, and YouTube. Thank you very much.